And so within time, what we have are these original aerosol droplets becoming smaller and smaller until they're essentially the size of a droplet nuclei. These can be basically the size of a virion, so they can be as small as about 0.02 microns in size, making a certain air filtration technology challenging to filter out these small contaminants. So looking at a little more into the droplet nuclei, we can see first in this table on the left, the large or small droplets before they become a droplet nuclei are fairly limited in the distance that they can travel. And we've all probably heard of the distance of 6 feet or 15 feet for sneezing. Now that distance refers again to these large droplets, not the droplet nuclei. The droplet nuclei can also cause infections, so we have to be concerned of those as well. And we can see that regardless the source, these droplet nuclei can travel a very long distance, and they can stay suspended essentially indefinitely. So looking at this figure towards the bottom, we see that HEPA filtration devices typically only filter out particles larger than 0.3 microns. So this leaves essentially the virions or the naked viruses essentially unfiltered, and as well as a large fraction of the aerosols that are generated from coughing or breathing. So what's needed is a technology that's effective on very small contaminants, particles smaller than 0.3 microns. This table, I won't go through it in detail. Welcome to look at the details during the slides at a later time. I just really wanted to highlight the different types of air cleaning technology. At the top, we have the photocatalytic oxidation. And if you notice, for the treated pollutants, this technology has the biggest range of pollutants that are treated. So it works on VOCs, it works on airborne microbes, it also works on allergens, odors, and other contaminants. As we move down the list, some of these other technologies are a little more limited in terms of the types of contaminants that they can either filter out or remove from the air. So filtration basically only works on particles that are larger than about 0.3 microns. And again, that leaves a lot of contaminants in the air that are potentially unfiltered. We have germicidal lights that are useful, but the way these lights work, the microbes or pathogens have to be in close proximity to the light. So you essentially have to trap the microbes on a filter and then have the light in close proximity. There's also ozone that has been used, but there can be some potential health concerns with the use of ozone. There's also ionizers, but those typically only remove particulates, so they're limited in their use as well. So I want to talk a little bit about different types of technology that have been proposed specifically for dental offices and practices within. The chairside aerosol extraction unit is a device that can be placed next to the patient to extract aerosols and process them essentially through a HEPA filter. So this device is a kind of a reconfigured HEPA filter where instead of pulling air through the entire room through the device, it actually pulls aerosols and air directly in front of the patient. And so we can see based on the specs, some of the information I was able to find that these devices are good at removing particles greater than 0.3 microns. They do contain a UV light for a disinfectant system, but it's important to note that these lights will only disinfect or inactivate pathogens that are actually trapped on the filter itself. So for viruses that pass through the filter, the residence time is so short the UV light is not effective at inactivating them. So looking at the images here, I've kind of adjusted the color a little bit, which reflects kind of the concentration and mass of aerosols being produced. And this image here on the left shows a very large cloud or mass of aerosols. The image on the right shows a much lesser concentration. So if indeed the extraction device was pulling the same mass of aerosols through the inlet here, we would expect probably to see some darker brownish, yellowish colors actually being taken in to the extraction inlet. And so again, these devices could be good in reducing the number of aerosols, but it's important also to check or try to find test results to demonstrate the level of virus inactivation passing out the air outlet, essentially. There's also negative pressure systems that have been used for air purification. This, again, is essentially a modified HEPA filtration device. It's good down to 0.3 microns. It also uses a UV light to help sterilize viruses and bacteria, again, that are trapped on the HEPA filter. One of the limitations of this technology is it requires a lot of air changes per hour to be effective. Another potential limitation of HEPA filters and filtration technology in general is that they are ineffective at removing pathogens or viruses or contaminants on surfaces. So that's a limitation. And then again, coming back to the size limitation, we see here the coronavirus is about 0.1 microns. And so you need a technology that's capable of removing very fine contaminants. Here's kind of a diagram of how the negative pressure filtration system works. So looking at the room environment, if indeed there's only one patient in the room, then this technology could be useful in terms of isolating potential pathogens from the rest of the HVAC system. However, it is important to verify this up here, that there are no, the red arrows are indicative of contaminated air, so that there would be no viruses or VOCs exiting this environment. The other potential concern for a situation like this is, what if you had another patient in the room, and then this patient is potentially producing bioaerosols that are being circulated right past the other patient. So there are some limitations to this type of technology. We can also see that bioaerosols can be moved from one room to another through HVAC systems. They can also be moved from outdoors to indoor facilities through the fresh air vents. So those are all factors that need to be considered when trying to find the best technology. Far-UVC lights is another promising technology that has been investigated quite a lot in recent years. This study shows one of the first studies actually that shows the promise of Far-UVC lights in terms of inactivating pathogens. This study showed a greater than 95% inactivation of influenza virus. There are some limitations with this technology, primarily the intensity or the effectiveness of the light decreases substantially with distance. So the intensity of light drops by the fourth power as you increase distance. So this is one of the main limitations of this technology, but it's a very active area of research currently, and could have a lot of promise, primarily for reducing pathogens in indoor facilities, both in the air and on surfaces. However, this technology is likely not to be very effective for other types of contaminants. So PCO technology is, well, it stands for photocatalytic oxidation. And this technology was actually developed more than 20 years ago by NASA. It is the most effective air purification technology for killing viruses. And that's because this technology gets around the size limitation and the filtration mechanisms, which are limited by size, by breaking down the contaminants chemically into CO2 and water, essentially. And so there are results showing greater than 99.9% inactivation of many different pathogens, including viruses and bacteria. This technology has been implemented in many different industries, and it's been proven safe and effective, and has essentially no potential harmful effects for human health. So I'll talk a little bit more about the safety and the effectiveness of this technology here in a couple slides. I want to point out in this slide kind of how PCO technology works over a wider range of contaminants than other standard air purification technologies. Over here on the far right, we have the standard HVAC filter, which is only good at removing large particles, usually greater than 10 microns. HEPA filters are, again, a filtration device. They go down to 0.3 microns. So they work for a lot of contaminants, but when you look more at the, say, volatile organic compounds or viruses, even the ultrafine contaminants, technology is not as effective. There's also electrostatic air filtration. This is basically ionizers, and they can be effective on particulates, but they don't work very well for pathogens. And then the active PCO technology or the gas phase PCO technology can actually work over the full range of contaminants. It's important to note down here on the bottom that approximately 90% of all indoor contaminants are less than 0.1 microns in diameter. So it's important that we implement air purification technologies that address these ultrafine contaminants. And that is one of the reasons actually PCO technology was originally developed by NASA. They had a problem with VOCs, ethylene in particular, in contained environments where they were trying to produce food. During the production of fruits and vegetables, these plants release ethylene. Ethylene is a hormone that can trigger fruits and vegetables to ripen prematurely. It can also cause them to rot prematurely. And so they had to find a new technology to remove ethylene, a VOC, which cannot be removed by filtration devices. So PCO technology was created and implemented for this use, and it was also found to be safe in terms of zero byproducts being produced. So that was a very important constraint for this technology, the development of this technology, since it was being used in a confined space. So since then, we know quite a bit about PCO technology. There are over 35,000 peer-reviewed publications specifically on this technology. You can see over the last 10 years, there's been an exponential increase in interest in publications on this technology. And this is not just an air purification technology. PCO is used for water treatment and water purification, as well as wastewater treatment. It's also used in food processing facilities and a lot of different other applications. Some of the first articles published on this technology go back to the 1970s. If you refine PCO technology by titanium dioxide, which is the catalyst that's used inside of these PCO reactors, the vast majority of them, there's still over 2,000 peer-reviewed publications specific to titanium dioxide and PCO technology. So this, there's a lot of background information, a lot of safety information, and a lot of information on the effectiveness of this technology. So the engineering and design of these PCO units is it's actually can be quite complicated to get all the aerodynamics right, to get the reaction chamber functioning right, and to get the production of these multi-cluster ions in the gas phase. And so I'll talk a little bit about how different types of PCO technology compare. The gas phase PCO technology is the most, I guess, aggressive in terms of cleaning indoor air, because it gets around the limitation of having to have a large number of air changes per hour to clean the air. And there's some graphs I'll show in a minute to kind of explain that. NASA licensed this technology for commercial use back in 2003. Since then, it's been used in medical applications, the food industry, military, as well as residential and commercial applications. There are over 4 million of these gas phase PCO reactors currently in use. and they have been specified for the norovirus and the MRSA protection plan for various industries like restaurants, public schools, and hospitals. So I want to talk a little bit about how the process actually works, how the light interacts with the catalyst to produce these air cleansing molecules, essentially. So when we have UV light that strikes the catalyst, titanium dioxide, a reaction occurs basically where on the valence band there's an electron hole that's produced. On the conduction band you have an excited electron. So this electron hole basically reacts with a water molecule that produces a hydroxyl radical, an OH molecule. At the top where you have the excited electron that reacts with oxygen to produce a superoxide anion. So this process is carried out in the presence of oxygen and water to create superoxide anions and hydroxyl radicals. And these anions and radicals are very effective at breaking down organic pollutants. And they convert the pollutants into water and carbon dioxide. So there are no harmful byproducts in this reaction. This shows essentially how these superoxide anions and hydroxyl radicals interact with pathogens to inactivate the pathogens. And the way that works is they basically cause a membrane rupture that then causes the potassium to leak out of the cell, which then essentially kind of desiccates the cell, rendering the DNA and RNA ineffective. And again, the byproducts of this reaction, when the pollutants interact with superoxide anions and hydroxyl radicals, you're left with CO2, water, and mineral acid. So not all PCO technology is based on the same engineering and design principles. And there was a study back in, let's see, 2015 that really tried to bring attention to this fact that some of these products on the market that claim to be PCO units do not actually have the same level of engineering and design as the PCO units that are based on the NASA developed PCO technology. And I try to highlight that here with this table, for example. So this study, I believe, looked at about 15 different air purifiers. These air purifiers were produced, I believe, in China and Korea. And I guess the price tag on some of these air purifiers is anywhere from $50 to $150. And so the engineering on the internal mechanisms of these air purifiers is somewhat questionable. To get this reaction working, you need a very high intensity broad spectrum UVC light. Those bulbs usually run $300 or $400. So that's kind of a indication of potential differences within these units. You can also look at the type of reaction core that they used, or the substrate in which the catalyst was put on. And some of these carbon cloth, fiberglass, these really aren't recommended or utilized in the peer-reviewed publication articles that actually show how the PCO process works. So this study, one of the main objectives of it was to basically bring to try to get some standard methods developed that allows for the testing of these PCO products. In other words, to have standards that like you have for HEPA filters, where they have to filter down to 0.3 microns. Currently, there are no standards regulating manufacturers and the PCO air purifiers that they produce. And so that's one of the things that we are trying to help clarify with the general public is this technology does work. It is very effective. It's been shown to be effective in many different studies. But again, there are no regulations controlling manufacturers from calling a device a PCO unit, even if there's technically no photocatalytic reaction occurring inside. Here is just a collection of some studies that use different types of PCO reactors You can see there's different types of catalyst here. Many have been incorporated with different types of metal ions that make the titanium dioxide more effective. We see that there's a lot of detail in terms of the preparation and the coating method to put the catalyst on the substrate or the PCO reactor. And we see over here in terms of the percent removal, many of them are capable of removing 99+% of the contaminants. We have a wide range of contaminants here, as well as looking at formaldehyde on the bottom table. These units are effective about 95% or more removal of these contaminants. So there is variation based on the engineering and design of these units. If they're engineered well and they have the proper components, the proper catalysts, and the proper preparation method, the vast majority of them perform very well. This slide provides a little more detail on some of the mechanisms that are used to help engineer these titanium dioxide photocatalytic coatings. So a lot of times they use these honeycomb monoliths because they have a very high surface area. And the titanium dioxide is often treated with porous silica or some other metal to make it more reactive. We see by using the silica here, we get a much greater surface area in these compounds. And that basically makes them more reactive. So they're able to produce more superoxide anions and more hydroxyl radicals when irradiated by the same light intensity. This shows what the coating looks like when placed on a glass surface or a substrate. It's a very thin coating, and it's essentially highly effective because you have such a high surface area. You don't need layers of coating. Oftentimes, these are just well less than 0.5 microns in deposition thickness. This is kind of a diagram showing the internal mechanisms of one of the PCO cells. We see we have this honeycomb structure, which is surrounding a broad spectrum, high intensity UVX lamp. And when that light shines on the catalyst in this honeycomb structure, which is often created with multi-metallic catalysts, titanium dioxide, as well as other elements in there, it produces a superoxide anions as well as the hydroperoxides, and those then actively seek out contaminants. So here, this diagram shows these multi-clustered ions will seek out contaminants. When they interact with the contaminants, they break them down, creating carbon dioxide in water. And this is a very rapid process as they move not only with the airflow, but through diffusion mechanisms as well. This diagram shows kind of how the pathogen cells, the lysis of the pathogen cells occurs. And so they basically desiccate these cells by delivering a very minute electrical charge to the cell membrane that then causes the potassium to leak, which ultimately will render the pathogen inactive. These multi-clustered ions cannot penetrate cytoplasm, so they cannot affect human skin cells or the DNA and RNA, just the cell membranes of pathogens. Just want to go through a few test results to kind of highlight some of the effectiveness of these gas phase reactors. These test results are specific to the UVX reactor. And we can see here for the norovirus, which is a single-stranded RNA virus, this is highly contagious. We see that there's a greater than 90% inactivation of these microorganisms with the use of gas phase PCO technology. And this is both for air and surfaces. For the swine influenza virus, we also see similar results where PCO technology is effective. This test was done on a stainless steel surface, showing a 99% microbial reduction in swine influenza. And again, like most viruses, they're spread through coughing, sneezing, touching contaminated surfaces, and by cleaning not only the air and the surfaces, this technology provides an extra level of protection for reducing the spread of certain diseases. This test also shows a 99% reduction in the avian influenza. This is also on a stainless steel surface, and there is concern of many viruses that, as they mutate, they can become more dangerous and can potentially pass from human to human. So, trying to find technology that can control or reduce the spread of viruses both in the air and on surfaces is critical. We also have test results from the UVX reactor for a simulated sneeze showing about a 78% reduction, essentially an instantaneous reduction in microbial aerosols within about 3 feet of the test. And so again, this process is very fast. It's an active air purification process. So rather than trying to effectively pull the aerosols generated, by a sneeze through a filtration device, the gas phase PCO reactors sends the air cleansing molecules out to the source of the contaminant, out to the source of the contamination, or where the aerosols are actually being produced. This just shows a summary of the test results. We can see there's a wide variety of pathogens that were tested, both viruses and bacteria. On average, we have roughly a 99% reduction, some as low as 97% reduction. We also can see other compounds were tested in addition to pathogens. Over 60 volatile organic compounds were tested, with an average reduction of about 91%. There were also inorganic compounds tested, about a 90% reduction. Here's ozone. So many air purification technologies, or not many, but some, especially ones that generate ozone, can actually cause issues for indoor environments when these molecules can't break down. And so having this process, which can actually break down ozone, can be beneficial, especially in urban environments where you may have high concentrations of ozone outdoors. That does inevitably end up on the inside the indoor environment as well. And so removing VOCs is very important. Wanted to talk a little bit about how gas phase PCO technology is likely to be very effective on COVID-19 based on previous test results. We see that there are 2 types of viruses. They can be enveloped or non-enveloped. This technology, the gas phase PCO, has been proven effective on both types of viruses. Previous studies have shown that the UVX reactor is very effective at killing both swine flu and avian flu viruses. This is H1N1 and H5N1. They found a 100% reduction in 24 hours. Now, since COVID-19 is very similar to both of these viruses, the H1N1 and the H5N1 are surrogates, it's clear evidence that the gas phase PCO reactor should have a significant impact on the current strain of coronavirus. If we want to look at how the morphology changes with time under the presence of photocatalytic oxidation, we can see that within 12 hours, the morphology of different, these are mold spores, but it also works for pathogens and viruses as well. You can see the actual morphology, the structure itself has been broken down, essentially mineralized into carbon dioxide and water. And we can take a closer look at that, looking at AMF image, and we can see this is for E. coli cells. The A is before photocatalytic treatment, the B is after. I wanted to point out though that this is only 1 minute of photocatalytic treatment, and you can already see where the white arrows are, that there are sites on the bacterial cell that have been damaged. So going back 1 slide, doesn't necessarily take 12 hours to inactivate these viruses. Many studies have to be done on the order of 1 to 5 minutes while the viruses are still viable to get data on this process because it is so fast. PCO technology has been utilized in medical facilities. This particular type of PCO technology is what's known as surface-bound PCO technology. So it's more similar to HEPA filtration, except instead of using filters and a filtration mechanism, it actually uses the PCO reaction chamber within the unit, which then breaks down viruses, pathogens, and VOCs to carbon dioxide and water. So this is a case study showing the implementation of the surface-bound PCO units within a hospital ward, and within minutes, the study found a 92% reduction in bacterial counts. This was back in 2001, so again, this technology has been in use for quite some time. It is listed by the FDA as a Class 2 medical device, and they produce no ozone and no harmful byproducts. The one disadvantage of using the passive PCO technology is that you can see, because it's not a gas phase active PCO technology, each room has to have units located within the room to treat that air, because there are no air cleansing molecules being released into the environment. All the air within the environment must be pulled through the filtration device, through the PCO device itself. Now, the gas phase reactors are different in the fact that they actually release these air cleansing molecules throughout the indoor environment. And so for doctor or medical and dental offices, we can take advantage of this gas phase PCO technology to provide optimal treatment in these facilities. So I want to walk through just a couple examples of floor plans and how you might implement this technology for, I guess, the most efficient coverage within these types of offices. So I'm using as an example the UVX reactor because we have lots of data and information on its effectiveness and how it works. There's over 10,000 hours worth of testing and studies that have been done on this particular reactor. And so the UXGR40 unit is a slightly larger, more powerful unit than the UXBL20. And I'll walk through some of these examples and hopefully will help you see the strategies or the best ways to implement this technology. There are a few factors to consider when implementing PCO technology in medical and dental offices. The biggest factor, or the most important factor, is probably the number of operatories. And this is where the procedures are occurring, and this is where the production of the aerosols are occurring. The other factor to consider is the number of occupants. Square footage is important, but the number of operatories and the number of occupants is more important than the square footage, because that is what determines the viral load or the bio load in the facility. And what we have been recommending for dental offices is the use of these essentially standalone units that could either be mounted on a wall or placed on a desk, as opposed to induct systems. The induct systems are essentially less ideal because in these dental offices, you tend to have areas where there's a concentration of aerosols, essentially the operatories, and then you have other areas where there are no procedures occurring, and you're basically just trying to treat the area for the number of occupants. And so what you can do is you can essentially overload the area where the aerosols are being produced with a heavier density of PCO reactors, essentially. And then the areas where you don't have the aerosols being produced, you can use the smaller units. If you tried to do something like this with the induct systems, you essentially would have to scale the entire floor plan to provide enough treatment for this area to offset the production of the the bioaerosols, which would basically mean you're over treating this area. Now there are no health effects to putting one of these units in a small room, but in terms of cost effectiveness, it's less cost effective because you wouldn't need the same level of PCO implementation in this area as you would in areas where procedures are occurring. And maybe this next slide will help clarify that a little bit. So if you have closed operatories that are closed off from the air circulation, we recommend placing one of the smaller units in each of those operatories. Again, there is no danger to over-treating the area. The concentration of the air cleansing molecules coming out the nose of the reactor is about 0.01 to 0.02 ppm. The concentration of these molecules outdoors on a sunny day is about 0.03 ppm. So there is no danger in having a high concentration. It's just a little less cost effective this way when the operatories are actually sealed off. But again, trying to implement this with an induct unit, you would have to essentially over-treat areas that don't have a production of aerosols in order to get a high enough concentration in these rooms where you do have aerosol production. Just want to go through a couple more of these to kind of give an idea. This is a larger floor plan. We can see that these GR40 units are capable of treating about 2 or 3 operatories, especially when they're in this open bay design. And so these air cleansing molecules will actively disperse throughout the entire facility. And then here again, with the reception area and other areas where you don't have procedures occurring, you can use the smaller units. So essentially, we're concentrating the PCO power with the large units where all the bioaerosols are being generated, and then using a less concentration down here where you're essentially just treating for the number of occupants. That would be essentially impossible to do with the induct systems unless you put enough capacity in there to provide this level of treatment throughout the entire facility. And just the last one, looking at kind of the layout, we can see here using one of the larger units to treat about 2 of the operatories, and the smaller units again concentrated on the other side of the office where the treatments are not occurring. Just a few images of what some of these standalone units might look like placed in the dental office. Again, they can go on the wall in between operatories. They can stand on the counter or desk. And again, they're effective. The actual placement or the location of their placement is not as critical as a passive filtration device because these molecules are actively circulating and dispersing throughout the environment. Okay, I want to spend just the last few minutes talking a little bit about multifunctional photocatalytic coatings. These coatings basically utilize the same processes and mechanisms that we talked about in the PCO air purifiers, except that these are coatings that can actually be placed on surfaces, all sorts or all types of substrates. It works for plastic, fabrics, glass, metal, painted surfaces, and porous surfaces as well. And these surfaces are self-cleaning. They are antimicrobial, and they actually clean the air as well, based on the same principles that we had discussed. These coatings are primarily made with titanium dioxide. Titanium dioxide is used in many applications. It has medical applications. It's also used to help sterilize, to have sterilized coatings for hospitals. They sterilize implants as well using these coatings. So they're essentially very safe. They're used in common household products like toothpaste and sunscreen. And what the difference is, the titanium dioxide has been heated up to 600 degrees Celsius under high pressure to have it take on a photocatalytic structure, essentially, to where it responds to light, both UV light as well as visible light. And so we'll take a look at that here. So these bar graphs show kind of the reactivity of the coating when exposed to light. The two bar graphs on the far right of each panel represent visible light. The ones in the middle are UV light. And so you can see for panel B, there's not much activity in the visible light spectrum. These are how the coatings were initially developed, but over the past 10 plus years, the titanium dioxide has been doped or infused with other components like silica, which makes them more reactive to visible light. And so you get a higher output in the visible light spectrum. This SEM image shows how these titanium dioxide coatings are dispersed on the surface. Oftentimes, they use a sodium hydroxide as a dispersant to help get a more uniform coverage and a better better reactivity with light when you have it dispersed at this level. These coatings, because they are so thin, they are essentially transparent, and maybe you can see a little bit of a whitish effect if you apply a very high concentration. This is about 10 coatings worth. For medical and dental offices, you would put on 1 to 2 coats at most. So essentially it would be completely transparent on any surface. This is a graph from a study that was done that looked at the reduction in bacterial burden on hospital surfaces using this titanium dioxide coating. And what we see that there are 8 surfaces that were tested: walls, doorknobs, bathroom rails, bed rails, countertops, and a few others. And as we see here, moving through time from 0 months out to 12 months, that these coatings are very durable and very effective. So at the start of the study, many of these surfaces had high levels of contaminants. With time, these contaminant levels dropped. Essentially, all of them are below the benign level, except for the countertop here, which is very close. This yellow line shows kind of the average concentration of microbial counts on surfaces in hospitals that have used copper surfaces. So this was a technique that's been used for a while. Other metals like silver ions have been used as well. So looking at this is a very promising technology. It's been used in many applications, and I think also it has excellent promise for use in dental facilities. And so some of the questions might be where to apply this. It can go on the walls, the light fixtures, windows, any area that receives light, especially high touch surfaces, countertops, the dental chairs, equipment. This can also be applied on fabric as well. So there is essentially numerous areas where it could be applied and useful for many ways. It's very easy to apply. You can simply wipe it on or use a trigger spray application. And in terms of longevity, on high touch surfaces, we would recommend reapplying about every 2 to 3 years. We've seen many studies where these coatings are still very effective after 1 to 2 years of frequent cleaning the surfaces multiple times a day with chemical cleaners and detergents. So they withstand that as well. On areas that aren't touched very much, like walls, these coatings can last up to 10 to 15 years. Just real quick, I just want to spend like maybe just a minute talking about some of the ways that you can test the effectiveness of PCO technology. There are ion meters available that can help you gauge the coverage of the PCO units by making sure if you go in an area where you think there's not very, the air circulation is limited, you can use an ion meter to verify that the air cleansing molecules are reaching that area. There's also ATP meters, which measure hygiene levels on surfaces. They give readouts in about 15 seconds, so you can measure multiple surfaces both before and after and get a comparison of how effective this technology is. There's also, I guess, simple ways of doing this as well. There, more is not very quantitative, but it can give you an idea of how well this technology is working. It's basically using auger plates and going to certain areas like the front desk or the chair, and then testing before and after. It's just important that you keep the conditions controlled as best as possible when doing these tests. So in other words, incubate them at the same temperature, the same number of time, the same, collect them from the same locations and things like that. So I want to go ahead and move on to the questions now, but before we run out of time. If anyone has any questions.
Yes, okay. First question. Active pure scrubber by Aeros claims to be NASA certified PCO. We plan to attach it to our central HVAC unit instead of individual small units. Is this a good PCO unit, and is a central HVAC unit sufficient?
Okay, I am not familiar with the specific specs of that particular unit, so I would have to look more into the details of, I guess, their test results and some of the specs in terms of, you know, the cubic footage of air that it treats, and to answer that question properly. I'm sorry.
Next question. Should we even have open bay treatment rooms with COVID-19 since aerosols can travel so far? Aerosols generated in one dental chair can be inhaled by the patient in the next chair 10 feet away.
Yes, so I guess that's a good question, and it is, I think, you know, ideally if the operatories were closed, there is more of a control mechanism from preventing these viruses to move from patient to patient or room to room. But if we think about one of the diagrams I showed earlier, and these virons being very small, they're able to move through the HVAC system. So without a technology like PCO implemented in place to actually destroy the pathogens, while they're still in the aerosol phase, they can still travel even if the operatories were closed. So you need something that actively cleans the air. Filtration devices are too slow.
All right, next question is a three-part question. What is the risk of emissions of harmful products like ozone or formaldehyde? Is there a mercury bulb which is subject to damage? And lastly, is this good in basement setting?
Okay, so in terms of risk of byproducts, that is dependent on the actual reactor within the PCO device. So I can't speak for some manufacturers and some products that, you know, are $100 or $200. Some have been shown to produce byproducts. I can say that for the engineered PCO units that have testing data and information on that, there's literally dozens and dozens of different reactors that have been shown highly effective in numerous studies in not producing ozone, but actually reducing ozone and reducing formaldehyde. I think I showed a table where there were maybe 4 different reactors, and they all showed about a 95% reduction in formaldehyde. There is a small amount of mercury within the bulb, but the bulb is contained within the PCO reaction chamber. And when the bulbs are replaced, there is a return box that comes, and so the old bulb is put in there and sent back to the factory. The factory recycles the components and disposes of the mercury properly. I think there's only like 1 mil of mercury in there. And I'm sorry, the last part of that question?
Basement setting.
Oh, yes. So this is very effective in a basement setting. The PCO technology is very effective at destroying mold and mold spores that are in the air. So that also helps.
All right, next question. What maintenance is required for PCO reactors?
So there is very little maintenance. There are no filters. The only thing that's required is every 30 months, you're supposed to replace the reaction chamber. So it kind of unscrews like a light bulb, and then there's 2 little screws that hold the reaction chamber in place. And that's the only maintenance.
Would there be a benefit to the duct system along with the larger units in the dental operatories?
So yes, I guess that's up to the objectives of the individual and what they're trying to achieve. Essentially, you could do an induct system that provides an overall level of treatment that you would need for essentially all areas but the operatories. Then what you could do is come back with the standalone units and add additional units near the operatories to essentially have a higher concentration or higher output of air cleansing molecules in those particular areas, and then the rest of the facility would have the general coverage from the induct system.
Do the big three dealers sell these?
Okay, I'm not familiar with the big three essentially, but lots of different manufacturers sell PCO units. I think you want to look, I think the gas phase PCO units are more advantageous for dental office practices than the passive PCO units. And just a quick note, when comparing other units, I would make sure that the bulbs themselves are rated for about 25,000 hours. Many manufacturers use bulbs that maybe last for 8 to 12,000 hours, and even from day one, the intensity of those UVC bulbs is probably not as high as it needs to be.
Okay, we're going to go with one more questions. For all other questions, we will be putting a Q&A that will be sent out to you. In regards to the presentation, will be available to you as well in a link. Last question. On a dental chair which is disinfected with hydrogen peroxide wipe, would the coating last 2 to 3 years?
Yes, the coating should last at least 1 to 2 years, even if the surface is cleaned 7 to 10 times a day. I believe I've seen studies indicating that. And the reason with that frequency of cleaning and timelines, most studies typically don't last for more than 2 years, but the coating showed no deterioration at the end of the studies, which is why we can say, the minimal should last, at least 1 to 2 years.
All right, thank you, Jason. Dr. Joaquin, over to you.
Thank you so much, Dr. Field, for a very informative presentation and for sharing your expertise. As a reminder, attendees will receive a SurveyMonkey link following today's session. Please stay logged in and complete the survey to receive your CE certificate if you are seeking dental credit. I hope you could join us again for our next webinar tomorrow, May 8th, on vaping, the new generation of tobacco addiction. For additional questions or information about today's presentation or future programs, please feel free to contact me at swakim@zufallhealth.org. Be well, stay safe, and enjoy the rest of your day.